We're going to move on to the second presentation with Dr. Cairo. We're going to dive deep into the early stage of HER2 positive disease.
Absolutely. So we're going to focus primarily on really the highest risk early HER2 positive breast cancer, because that's where the newest data is coming out. So in the sort of initial landscape, we've had for the highest risk HER2 positive early breast cancer, which has been previously defined as, T2 or node positive disease. We've been using neoadjuvant taxane-based chemotherapy in combination with trastuzumab plus pertuzumab, followed by surgery and radiation, and then depending on your response, pathologic complete response, TH plus endocrine therapy if indicated, and for residual disease, a TDM1. But there are two new opportunities, two trials that were reported at ESMO in 2025. You all have probably had some opportunity to be thinking about them. DESTINY-Breast11, which brought T-DXd into the neoadjuvant setting, as well as DESTINY-Breast05, which brought T-DXd versus TDM1 in patients who had high risk or residual disease after prior treatment with neoadjuvant chemotherapy. So beginning with DESTINY-Breast11. So DESTINY-Breast11 phase 3 trial, a neoadjuvant triple arm trial, although one of the arms did drop out because of safety. Arm 1 was T-DXd alone for 8 cycles. Arm 2, T-DXd for 4 cycles, followed by THP for 4 cycles. And Arm 3, dose dense AC for 4 cycles, and then THP for 4 cycles. There was no TCHP arm. This was an international trial. Nearly 50% of the patients were in Asia. And so I think that influenced some of the choices regarding the standard of care arm. The eligible patients were early stage and high risk. And this is a pretty significant high risk group. So these were patients who were either T3, any nodal status, or node positive, any T status, and it even included patients with inflammatory breast cancer, a traditionally extremely high-risk group. Notably, primary endpoint was pathologic complete response. With around 300 patients in each arm, this study was not powered to evaluate event-free survival and overall survival. And so in geographic region, there was a preponderance for enrollment in Asia, although the many patients in the rest of the world were also involved. The hormone receptor positive group was appropriately represented at around 70%. And for the nodal status, consistent with the inclusion criteria, the nodal status was also consistent between the 3 arms at around 88-89%, reflecting the high-risk disease that they were looking for in this study. So looking at the pathologic complete response on the top row, and then the RCB 0 and 1 response on the bottom row, we're going to be looking here at the T-DXd THP arm versus the AC THP arm. I think it would be wise for me to note the reason why the T-DXd only arm was ultimately not concluded. The Independent Data and Safety Monitoring Committee determined that it needed to be stopped because of futility, because it did not look like it was going to be equivalent to the other arms. So T-DXd followed by THP versus AC THP. So in the pathologic complete response rates and the intention to treat population, there was an 11% difference favoring T-DXd THP versus dose dense AC THP. And I think it is important to note here that with a 67.3% pathologic complete response rate in the T-DXd THP arm, this is the highest reported PCR rate for an early stage HER2 positive breast cancer study. And this was consistent whether you were looking at the HER2 positive group or the HER2 negative group shown on the right on the top row. HER2 positive group, the delta was 9.1% in favor of T-DXd followed by THP compared to the standard in this study, and hormone receptor negative, even better at 16%. Now, if you didn't want to just look at PCR alone, but instead if you look at the RCB 0s and 1s, RCB 1, of course, being close to a PCR, RCB 0 having a lot of overlap, then you're still looking at a 12% delta between favoring T-DXd THP and the intention to treat population, and that was consistent in the hormone receptor positive and the hormone receptor negative arms. So looking at we do have a slide for the event-free survival, remembering that the trial was not powered for EFS and overall survival. There is a numerical difference between the two arms, with the T-DXd arm, T-DXd THP arm having about a 97% EFS at 24 months versus a 93%. But importantly, the event maturity was only 4.5% and underpowered. This is a good time to note that the post-neoadjuvant treatments were balanced between the T-DXd THP arms and the dose-dense AC THP arms. In both arms, more than half of patients who did not achieve PCR received post-neoadjuvant TDM1. But I do think it's important to notice that nearly half of patients without PCR didn't receive TDM1. This probably reflects, again, the international nature and access to TDM1, particularly in Asia. But I think it's going to be important to remember this when we think about where do we use our antibody drug conjugates and where are they going to provide the most value. So in the DESTINY-Breast11, if we're going to look a little bit more at PCR and event-free survival now this is the T-DXd only versus the dose-dense AC THP. Where did it fall down? So if we're looking on the left-hand side here, the primary analysis, the PCR rate in the T-DXd times 8 group, 43%, doesn't look that great, compared to dose-dense AC THP arm at 56%. But it's important to know what they did here. So at the time that the T-DXd arm was shut down, patients were permitted to transition to the standard of care arm if they were still on T-DXd. And a certain number of patients did, and those patients were therefore classified as non-PCR, making your PCR numbers look more drastic. In a pre-specified supplementary analysis where the switch to local standard of care was not automatically classified as non-PCR, but they actually went and looked at the Pathologic data, the PCR rate for T-DXd times 8 was 51% versus dose-dense AC THP 59%. Still not offering any kind of suggestion that ought to have continued, but just to give you some perspective. Now, in terms of safety, the overall safety profile of T-DXd alone was favorable, with reduced rates of grade greater than 3 AEs, SAEs. And ILD incidence was low and similar in both arms. But we really are looking in terms of the safety at the arms that are going to move forward for us. So this shows you on the left of my tornado plot, the T-DXd times 4 plus THP times 4. This is the arm that moved forward versus the standard of care dose-dense AC THP. Overall, similar rates of AEs, but grade greater than 3 AEs were more dominant in the dose-dense AC arm at about 56% versus 37% in the T-DXd THP arm. Any serious adverse events were also greater in the dose-dense AC THP arm at 20% versus 10% in the T-DXd THP arm. AEs of special interest. This was really surprising. So ILD, there was about a 4.4% drug-related ILD in the T-DXd arm, THP, versus 5% in the dose-dense AC THP. Now, I can't be the only person who's seen ILD with a taxane, but it has happened, and so I'm making an assumption that that might have accounted for the ILD in this arm. And when you're looking for ILD, you will start finding it. So left ventricular dysfunction was greater in the dose-dense THP arm at 6% versus 1.3% in T-DXd THP. Not surprising. This has historically been the main toxicity issue with adriamycin. When they were doing monitoring, they were doing high-resolution CT scans every 6 weeks with treatment. I think this is quickly or slowly becoming the standard of care, and they were doing echoes on a routine schedule. Also noticeable is in the dose-dense AC THP arm, there were higher rates of neutropenia, anemia, and your usual cytopenias. So the key takeaway points for DESTINY-Breast11, you've got the highest reported PCR rate in HER2-positive early breast cancer. This is the 4th trial to show no improvement in PCR with anthracyclines and a worse safety profile with anthracyclines. T-DXd alone was inferior in this high-risk patient population, and so I think this reinforces for us going forward when we're designing studies that sequential, non-cross-resistant chemotherapy may remain the best approach, as opposed to pulling something wonderful from the metastatic setting and trying to apply it broadly in the neoadjuvant setting. Similar rates of ILD, which I think was surprising. And you could say that the control arm study design was a bit flawed for comparison in the United States, where TCHP, I think, is really dominant. So just moving on to DB05, just remembering Catherine, which brought us with TDM1 at a median follow-up of 8.4 years. That absolute IDFS benefit was 13.7% compared to HP alone in patients who did not achieve a pathologic complete response. Jason, have I really used 18 minutes of my time?
You're good.
Okay.
I have a timer here.
I don't know where it went.
No, you're good.
Okay, just double checking. All right. So when we're looking at DESTINY-Breast05, we are looking at patients who were defined as high risk either at presentation, prior to neoadjuvant chemotherapy, or who had residual disease, axillary node positive disease after neoadjuvant therapy. And so you really did need to have some pretty high risk early disease, either T4 or N2 or N3 disease. And then after 6 cycles of chemotherapy with HER2-based therapy, you were randomized to T-DXd versus TDM1. Our patient characteristics were pretty well balanced, hormone receptor positive around 71%. Fortunately, 78% of patients in each arm did get Herceptin and Perjeta in the neoadjuvant setting, making this very relevant to our modern population. And this study with 800 patients in each arm was powered not only for IDFS, the primary endpoint, but also overall survival. So in the interim analysis, the IDFS is favored T-DXd versus TDM1 with a delta of 8.7% at 36 months. That gives us a hazard ratio of 0.47 and a significant p-value. Now, in the fine print, looking at categories of first IDFS events on the right, let's look at the CNS versus the non-CNS events. One of our questions regarding possible benefits of TDM1 is, could it help be preventative in terms of CNS events in the metastatic setting? Numbers are small here. You're looking at 25 events in the TDM1 arm versus 17 events in the T-DXd arm. And the additional efficacy analysis, on the left-hand side, I've got my subgroup analysis, everything, and all of the subgroups, including geographic location, all of age, all of the intent favors T-DXd. And again, absolute improvement in disease-free survival, 8.8%. The overall survival is not yet mature, although the hazard ratio is giving us hope at 0.61. The safety, notably, I'd say the nausea was notably increased in T-DXd at 70% versus TDM1. Now, I didn't show these slides, but they did at the San Antonio Breast Cancer Symposium bring the safety data out there, and the primary time when you saw the nausea in the T-DXd arm was in the first cycle. It was specified in the protocol that if you had started out with a 2-drug antiemetic regimen in the first cycle and then you had significant nausea, you could bump up to 3 drugs. And there was a smaller number of patients who started out with 3 drugs, and if you had 3 drugs, much less nausea, 2 drugs, much more nausea. So it is possible that a more aggressive antiemetic regimen could shift that over. And when you're looking at ILD, you do have more ILD in the T-DXd arm. Now we're looking at 9.6% ILD. And this is a little bit more consistent with what you see in the DESTINY-Breast trials. But it is notable that if you have 14 cycles of T-DXd, you're looking at 9.6% ILD, whereas when you had 4 cycles of T-DXd, you were looking at 4.4% ILD. And that might factor into our thoughts about when we use it in order to not only optimize efficacy, but also to reduce risk. And LV dysfunction was similar in both arms. So takeaway points, and this is pretty much my final slide. So how are we going to incorporate T-DXd into the treatment of early stage HER2 positive breast cancer? T-DXd for patients with high-risk HER2 positive disease following 6 cycles of neoadjuvant chemo had significantly improved IDFS and DFS compared to T-DM1. It's seen across all pre-specified populations. It's too early to conclude benefit, but there was some interesting data about less CNS metastases in the T-DXd group. It was associated with more ILD compared to DB11, presumably due to longer exposure. There was more nausea. I think that's probably manageable, and similar deaths attributed to treatment. So I think this is the question that we're probably going to want to discuss here. Neoadjuvant or adjuvant? Where are you going to use your T-DXd? Is more T-DXd better than less? I'm going to say that the answer to that might be no. 8 cycles of T-DXd was not better than 4 cycles of T-DXd followed by THP. T-DXd times 4 followed by THP was associated with less toxicity and increases PCR to really the highest numbers we've seen in an early stage trial, and could spare a subset of patients 14 cycles of T-DXd. But if you use T-DXd in the neoadjuvant setting and you don't get a PCR, then what are you going to do? Well, that's going to be very unclear. And THP alone might be sufficient for a subset of patient, and individualizing therapy to risk is critical. And I'm going to make a call here for studies that continue to do a risk-assessed assessment of the patient assessment when they are moving them forward in treatment. So new options, T-DXd times 4, THP times 4 in the neoadjuvant setting, or T-DXd times 14 in the adjuvant setting.
Fantastic.
Thanks, everyone.
Thank you so much. All right, questions. We have 5 minutes for questions. I'm going to start with the first one. I mean, you mentioned whether we're going to use it in the adjuvant setting or the neoadjuvant setting. But I want to start with the neoadjuvant setting. I hear a lot of people want to start with THP times 4 and then see what happens and then do the T-DXd. But that worries me personally a little bit, because that's not how it was studied. And the ILD that you mentioned, you are right. All the ILDs that happen with the taxane portion, not with the T-DXd portion. Would you be comfortable switching the order?
I don't think I would be comfortable switching the order. At this time, I would love to see a clinical trial that switches the order, one versus the other, or one that even assesses the response to THP, and then if you have an appropriate response, you complete another additional cycles, or if you don't have 2 additional cycles, or if you don't, you move on to say a T-DXd times 4. So perhaps based on a PET CT, perhaps incorporating some circulating tumor DNA clearance. I think there's lots of opportunities here to answer that question. Until that happens, of course, I'm probably not going to switch the order. I mean, order has not always mattered. AC versus TC, TC versus AC. You can give them, in either order. But in this case, there might be something special about giving the T-DXd first, and there might be some safety considerations.
The NCCN does recommend you can give it in either order.
Does it? NCCN's going to go for it. Okay, we'll do
whatever they want.
Everybody.
Yes.
But based on Compass, right, more than 50% of patients respond to THP alone.
Yeah.
So do you really need to incur the toxicity risk here, including potentially fatal ILD, right? Even despite aggressive monitoring happened on these curative intent trials, and it's sort of interesting, the comparison, the ILD with the AC-THP, because I've never seen that. Yeah. I'm only 29, but in my several years of clinical practice, I've never seen that. Thank you. I've never seen that. But it's interesting to me that more than half of our patients with stage 2, especially disease, could be cured with THP alone, which incurs minimal toxicity and doesn't need, so should we do imaging after THP and then introduce the idea of T-DXd for a short course? If they don't get a response to short course T-DXd and they have residual disease, are we going to give them an additional 9 months of T-DXd in the adjuvant setting? Like, let's be honest about where we're going here.
Yeah. Any question from the group? Yeah, Bashar.
Do we know that the radiographic response correlates with PCR? We don't know.
Radiographic response has been, I mean, anybody can step in here, but radiographic response has been used in, I think particularly, the Westerman Plan B trial?
An I-SPY.
They use an I-SPY.
They use an I-SPY.
Yeah, an MRI, I mean, clearing all disease on MRI may be associated with a higher chance of detecting a pathologic complete response, but nobody feels that it is good enough. And there were many studies that looked at imaging response and random biopsies, and they don't predict pathologic complete response. But what is interesting here, what comes to mind, is the data from TBCRC40 that was published, the collaboration led by Ben Park and his group at Vanderbilt, that clearing ctDNA was associated with good outcomes.
Yeah.
And so, and actually it was regardless of whether
similar to the PCR patient.
And this was
Even
triple negative
Yeah.
and HER2 positive. And so the question that comes to mind, and I agree with Heather, why not start with THP times 4? Because we know THP times 4 could be enough for some patients. We know that T-DXd times 8 is not.
Yeah.
And so why start with the one that you know is not enough and start with THP? I'm married to a pulmonologist, so I cannot be not worried at all about ILD. Of course I am, but maybe because I have her on speed dial, I feel more confident saying that if we monitor those patients closely, that rate of ILD or pneumonitis in the DESTINY-Breast05, DESTINY-Breast11 was not very concerning to me. One last thought, which is really important to point out in my opinion, is that T-DXd, I think the neoadjuvant setting failed as a single agent because it lacked the appropriate inhibition of the HER2 pathway. Because early on the disease, HER2 is very important signaling, and we know that dual inhibition is important. And I think that we were going to talk about DESTINY-Breast09, but in DESTINY-Breast09, the T-DXd plus P arm reported. The T-DXd only arm has not reported. So just food for thought. While I agree with everything my colleague said, I think there's a lot of unknowns that we just have to be very careful about. And at the end of the day, every patient is going to be different, I think.
Yeah. Any last question? Go ahead.
So with the data from DB05, is there a rule for some patients to still get TDM1 for tiny residual disease, more of like risk stratification of who would get a T-DXd versus TDM1, long term? I mean, TDM1 is pretty reasonably tolerable and doesn't have that fatigue, no risk of ILD, or are we completely crossed it out? Because even in the metastatic setting, there is still some hypothetical rule for TDM1 for some patients.
Well, what was your neoadjuvant? In the scenario, what was your neoadjuvant treatment? Did you treat based on DB11 in the scenario?
No, I'm talking about the adjuvant setting.
Yeah, but what
did you use in the neoadjuvant setting?
So pre-DB.
So pre-DB. So you use TCHP in the neoadjuvant setting, and you're thinking, for whom do you use, HP versus TDM1 versus T-DXd? I'd love to hear what everybody has to say about this, but
You'll hear from everybody at the end of today's
there you go. All right, so then I'll
in the Q&A.
see. I'm totally trying to dodge the question here because I think it's really difficult. I would say that I'd look pretty carefully at the inclusion criteria, for DB05, and I would really like to see positive nodal disease, after neoadjuvant therapy. I'm not looking, if you're looking millimeters of breast disease and completely cleared out nodes, I'm not sure that's my T-DXd patient. Maybe if I'm feeling extra saucy, that's my TDM1 patient, because they were included in the Catherine trial, and they had a 8.9% benefit versus HP alone. But there could be this intermediate spot here for patients who didn't get a PCR, but who weren't exactly quite so high risk at the beginning. Your patients who were highly ER positive, where you think you've got an escape mechanism happening here as well, and that, continuing to pound them with anti-HER2 therapy might not be the answer.
Fantastic. Thank you so much. All right.